Assalamu alaikum. Thank you everyone for being connected with me. Today I will start the series on pharmacodynamics, and here all the contents I have copied from Cadjung Basic and Clinical Pharmacology 14th edition, Lippincott Illustrated Review on Pharmacology 6th edition, Essential of Medical Pharmacology 8th edition. Writer is KD Tripathi, and I have also copied from lectures of Dr. Masud Rana sir, Chattogram Medical College, Pharmacology Department, Assistant Professor. So I hope all of you will be benefited from my this series, and here I will try to clear all the basic conceptions on pharmacodynamics. So you know that I have already published the series on pharmacokinetics. So at first I want to show you the basic difference between the pharmacokinetics and pharmacodynamics. So all of you already know, I think, but I just want to brief it. Suppose a patient come to you and he or she complains you that he or she is suffering from tachycardia or palpitations. So you decided that you will prescribe propranolol drugs for treating the palpitation. Okay, so you have prescribed the drug. Now the patient has gone to his house, and he or she took the propranolol. Okay, and the route of administration of this propranolol is oral intake. Okay, so when the patient took the propranolol drug orally, the drug at first goes to the intestine. Okay, through the stomach the drug come into now in intestine. After reaching the intestine, the propranolol drug will be absorbed. So now look at the picture. Propranolol is absorbed into blood. This is blood, that means circulation. That means now the drug has reached the circulation. This is called absorption. It is one of the important parameter of pharmacokinetics. Okay, now look at the picture. You can see here 1 2 3 4 5 6 7. That means 7 propranolol reached the circulation, just for example. Okay, and among the 7 propranolol drug, 3 propranolol is attached with plasma protein. This parameter is called plasma protein binding. That means whenever a drug reached the circulation, some of the drug is bound with plasma protein. This is called bound drug, and this bound drug is inactive. Why? Because the bound drug cannot escape or cannot come out from the blood vessels because they are attached with the plasma protein. So this plasma protein bound drug act like as a storage of the drug. Okay, and this 1 2 3 4, this 4 propranolol are free drug. Now free drugs are active drugs. Now this propranolol will come outside of the blood vessels and they reach into the liver, because you know that the venous drainage from the intestine, because this vein is draining the intestine. Now their destination is the portal circulation. That means the propranolol will reach the liver through which vein? Through portal vein. Through portal vein. Okay, look at the picture. So this is portal vein. Now we know that liver is the main metabolizing organ. Now suppose 1 2 3 4 propranolol reached the liver. Now among these 4 drugs, 2 propranolol is inactivated by liver. That means by metabolizing enzyme. So this metabolism process is known as biotransformation. You have known it, I think. So now 2 drug is inactivated. Okay, and this 2 drugs is active. So these 2 drugs will come outside of the liver and they reach the heart, which is why they reach the heart, because the target of propranolol is beta 1 receptor of this heart. That's why the propranolol is coming towards the beta 1 receptor through blood. So at first look at the it is just a journey of the drug. So from the site of administration, that means oral, from your mouth to just before the receptor, this journey is known as pharmacokinetics. Just after binding with receptor, all of the events which will be occurred, this is known as pharmacodynamics. That means everything that has happened before the receptor is known as pharmacokinetics, and everything that will be happen after binding of the drug with its receptor is known as pharmacodynamics. Okay, so this is the border. So this is the border between the pharmacokinetics and pharmacodynamics. This is the border. This is the border. Okay. Okay, so this is the basic conception. Now come to the point. So every drug, whenever we ingest a drug or we intake a drug, the drug plays any one of the four roles. Any one of the four. So which are that? These are either the drug will play the role of stimulation, or the drug will play the role of inhibition, or the drug will play the role of replacement, or the drug will play cytotoxic action. That means any drugs, whatever we have taken, the drug will play any one of these four effects. Okay, so look at the example. At first, now we will show you the stimulatory action of drug. Suppose if we give the adrenaline infusion, then what will do the adrenaline? Adrenaline will increase the heart rate and will increase the force of contraction, because the adrenaline will bind with the beta 1 receptor of heart, and the adrenaline now stimulates the heart to forcefully contract, and adrenaline will increase the heart rate. That means adrenaline just increasing the normal the function of the heart. Okay, so it is a stimulatory action. Look at another example. If we give pilocarpine, the pilocarpine will act on muscarinic 3 receptor of salivary gland. So muscarinic 3 receptor, I will discuss everything in details inshallah in next tutorials. So at first you have to know that muscarinic 3 receptor is a GQ coupled protein. That's why GQ protein coupled protein ultimately will lead to increased calcium concentration within the salivary gland, and this increased calcium concentration will lead to increased salivary secretion. That means pilocarpine is stimulating the salivary gland to secrete more and more saliva. That means the pilocarpine are playing a stimulatory effect on salivary gland. So these two are classical example of stimulatory effect of drug. Now look at the example of inhibitory action of drug. Most common example is benzodiazepine. So we know that what will do the benzodiazepine? Benzodiazepine will bind with the GABA receptors located on neuronal membrane. Whenever the benzodiazepine will bind with the GABA receptor, the affinity of the GABA receptors towards GABA will increase. That's why more and more GABA will begin to bind with the GABA receptor, and more chloride ion will begin to enter into the neuronal membrane. That's why neuronal membrane will be hyperpolarized and the neuron will be suppressed. That's why the signal transduction towards forward movement will be suppressed. That means the benzodiazepine is doing suppressive effects on your nervous system. Okay, so I will show you the structure of GABA receptor, then it will be cleared to all of you. Now look at the propranolol. It is also an inhibitory effect of drug. If we give propranolol will block the beta 1 receptor of heart. That's why the endogenous adrenaline, if you know that our body is composed of two autonomic nervous system. That means the autonomic nervous system is composed of two arms, sympathetic arm of autonomic nervous system and parasympathetic arm of autonomic nervous system, and our sympathetic nervous system is continuously synthesizing the adrenaline and noradrenaline. Okay, so suppose adrenaline comes here, but this adrenaline cannot bind with the beta 1 receptor. Why? Because propranolol already blocked the beta 1 receptor. That's why what does the propranolol did there? The propranolol block the site of adrenaline. That's why adrenaline cannot do its function. Okay, that's why the heart rate and force of contraction will be decreased. Now look at the example of replacement effect of drug. Suppose the most common and easy example is Parkinsonism. What is happening in Parkinsonism? We know that in Parkinsonism, the dopamine, endogenous dopamine concentration is reduced. That's why we are trying to give the patient externally dopamine supplement. That's why the deficiency of dopamine can be compensated by external source. So as the target of dopamine is central nervous system, so we should prepare the dopamine in such a way so that our externally given dopamine can penetrate the blood brain barrier. Because you know that in suppose it is a neuron, okay, and it is the blood vessels. Now our lucrative dopamine is here. So if the externally given dopamine is water soluble, what do you know? You know that there is a barrier. This barrier is called blood brain barrier. So if the dopamine is not lipid soluble, the externally given dopamine will not able to enter into central nervous system, because blood brain barrier cannot be crossed by a water soluble drug. That's why we prepare the externally dopamine in such a way so that it become highly lipid soluble, and so that the externally given dopamine can penetrate the blood brain barrier. That's why it is called levodopa. Okay, so this externally given levodopa now is enough lipid soluble. That's why this levodopa will enter into central nervous system, via crossing the blood brain barrier. Then here the levodopa will be metabolized into active form. That means levodopa will be converted into dopamine, and this dopamine will play the role on dopaminergic receptor, and it will compensate the endogenous deficiency of dopamine. So what have you looked there? That means we are trying to compensate the endogenous deficiency of dopamine by giving external source of dopamine. Another example is insulin for uncontrolled diabetes mellitus. So if a patient is suffering from decreased secretion of insulin, such as in case of type 1 diabetes mellitus, we will give the external source of insulin. That's why this insulin will enter into body, and it will act on insulin receptors in compensate of endogenous insulin. That means we will try to compensate the deficiency of endogenous insulin level. And another example is if a patient come to you suffering from iron deficiency anemia, then we will prescribe iron supplementations to compensate the iron deficiency. So this is the replacement effect of drug. Now look at the last number, that means cytotoxic effect. So some drugs, most commonly antibiotics. So antibiotic will kill the bacteria only. So this is called the selectivity of drugs. So this is called the cytotoxic effect of drug. Or anti-cancer drugs such as methotrexate, it will kill the malignant cell. So in previous 3 example, you have looked that the drug either stimulate or either suppress the endogenous effect, either stimulate or suppress the endogenous effect. But in case of cytotoxic action, the drug directly harm the cell, directly harm. It doesn't stimulate or suppress the action of cell. It directly causes death of the cell. Okay, so antibiotic will do harm to the bacterial cell, and anti-cancer drug will do harm to the malignant cell and as well as some good host cells. That's why. And another one is anti-helminthic drugs, antifungal drugs, that all of these drugs will hamper directly the cell. They will try to kill the cells. So this is called the cytotoxic action of drugs. So now look at the next example, next topics. So every drug, it doesn't matter what type of drug is, every drug will bind with any one of the 4 drug target. That means if we take a drug, the drug either bind with receptor, or bind with the ion channel, or bind with the transporter, or bind with the enzyme. That means a drug has any one of the 4 drug target, any one of the 4 drug target. Some drugs bind with the receptor, some drug bind with the ion channel, some drug bind with the transporter, and some drug bind with or interact with the enzymes. Okay, so we will describe it elaborately inshallah. So you have known that there are 4 drug target, very important information. That means receptor, ion channel, transporter, enzyme. Now at first we will describe elaborately about the receptors. So at first we will classify the receptors according to different headings. Okay, at first according to locations, the receptor can be located in 3 location of a cell. Look at the picture. Suppose this is a cell, and here the lucrative nucleus of this cell. So the outermost border of the cell is cell membrane. Okay, and this is the cytoplasm, and this is the nucleus. Some receptor is located in cell membrane, such as beta 1 receptor, M3 receptors, H1 receptors, and many of something. These are the most common cell membrane associated receptors. Okay, and some receptors is located in cytoplasm, such as the receptor for steroids. Actually there the only receptor is steroid, which is located in cytoplasm actually. Okay, and another one is thyroid receptor, which is located in nucleus. Okay, you know that in nucleus there is nucleoplasm. We will discuss elaborately about the thyroid receptor later. So in nucleoplasm the thyroid receptor is located. So this is the thyroid receptors. So cell membrane attached receptor, cytoplasmic receptor, and nuclear receptor. So according to location we will find 3 types of receptors. Okay, according to activity there are 3 types of receptor: active receptors, spare receptors, and silent receptors. Such as in heart, suppose in your heart, for example, you have 100 beta 1 receptor, 100 beta 1. Suppose this is the heart, and here I am drawing just for example 3, 4, 5, 6, 7, 8, 9, 10. So I have drawn here almost about 10 beta 1 receptor. So there are also 90 receptor which is located in the cytoplasm. In the cytoplasm actually it is just keep itself silent. Okay, suppose in here. So almost 90 beta 1 receptor is located beneath the cell membrane. Whenever there will be need, the receptor will be upregulated and they will come into the cell membrane. This is called receptor upregulation. Whenever there will be acquired the receptor. Okay, so if we give suppose we have given the patient adrenaline, so the adrenaline will bind with the active receptor, which beta 1 receptor is already located on cell membrane. The adrenaline will not get access to those receptor which is located beneath the cell membrane. Okay, so these receptors are called active receptor, which is found for the agonist. That means the 10 receptors are active receptors and these 90 receptors are spare receptors. They are not accessible now, but they will be upregulated if the patient or the person taking the antagonist drug for a long time. And there are another types of receptor, it is called the silent receptor. That means in which receptors if the drug binds but no effect will be shown. That means the drug is binding with the receptors but no pharmacodynamics is happening or no effect will be shown, such as plasma protein. Look at the picture. Here I have already mentioned that some propranolol will be free and some propranolol will bind with this plasma protein. But look at the figure, you can see here this propranolol is just attached with the plasma protein, but no function is happening there with the plasma protein. Just it acts like just a storage of this drug. So this plasma protein is called a silent receptor. Okay, so another example is adipose tissue. Suppose this is skin and these are the adipocytes. Many drugs, especially those are lipid soluble, those lipid soluble drug, they have a strong affinity to this adipocyte. Now they are trying to enter into this adipocyte and no action is happening within this adipocyte. Just the drug enter into this adipocyte and keep themselves just in resting position. That means the adipocyte is acting like a storage of that drugs. That's why the fat cell or adipocyte is also a silent receptor. That means drug is binding with the receptor but no effect or function is happening. Okay. Now in our next tutorial we will describe the most important things, that means the classification of receptor according to mechanism of action. So there are mainly several types of receptors according to mechanism, such as number one is ion channel coupled receptor. That means these receptors is coupled or attached with an ion channel. Okay, some receptors they are attached with G protein or serpentine. These receptors are also called serpentine receptors, which is attached with G protein. And there are some receptor which is attached with tyrosine kinase, or a portion of these receptors acts like tyrosine kinase enzyme. Okay, so I again repeat it, that means a portion of the receptor acts like tyrosine kinase enzyme, or this receptor is attached with tyrosine kinase enzyme. So I will show you in my next tutorial, inshallah. So another receptor is DNA coupled receptor. That means whenever the agonist for the receptor is come, then the receptor bind with the agonist, and this agonist and receptor complex goes to the nucleus and bind with the DNA, that means gene. Then they will transcribe a specific RNA, and then the mRNA is translated into protein, and then this synthesized protein will show the effect. That means at first the agonist will bind with the receptor, then the agonist receptor complex will enter into the nucleus. Suppose this is the receptor and this is the agonist. Now the agonist bind with its receptor. Now there is happened agonist receptor complex. This is called agonist receptor complex, and now it will go to the nucleus. Suppose this is the nuclear membrane and this is the nucleolus, and here these are the chromatin. Now this agonist receptor complex will enter into the nucleus through the nuclear membrane, and then this agonist receptor complex will interact with a specific DNA fragment. That means we know that a specific fragment of DNA is known as gene. So then this gene will be transcribed into mRNA. Then this mRNA come into the cytoplasm, and this mRNA will be translated into a specific types of protein. Then this protein will show its effect. So this is the mechanism. I will show you the picture from the Adjunct textbook, inshallah, in my next tutorial. So be connected with me, keep me in your prayer. Thank you everyone.